Welcome. My name is Gary Kaufman, and I'm delighted to be able to provide this webinar both live and on demand, Understanding and Leveraging Consultants. Here are my disclosures. Most importantly, I think, is I'm a proud AERC member for more than a couple of decades. Those of you know me know that number is higher rather than lower, and I have no conflicts with the content. This is what I think is important. Those of us who are respiratory therapists or maybe nurses and others listening to it, but it's important that we give to others, including ourselves. So that is my commitment to providing this education. Now, here are the learning objectives. Appreciate the drivers for consultant engagement and the goals that your executive management have set. If you don't know what they are, it's important that we get those. Understand information required by the consultant to ensure that you're prepared before their arrival. And I'll talk about this in the presentation. What we don't want to do is what I've done in the past. Oh, the Joint Commission is coming next week. I better get stuff together. So we'll talk about preparation and also how to conduct yourself during a consultant engagement and what you can do afterwards that virtually nobody does. And thirdly, apply this information that will allow you to meet the needs of the consultant and the executive management to achieve a successful engagement. It needs to be a win, and a win. A win for the consultant, a win for executive team, and a win for our departments. So start off, why do hospitals engage consultants? Well, consultants have worked with dozens or even hundreds of hospitals, and they've got an expansive knowledge of operations in small, moderate, large hospitals and health systems. So they, quite frankly, have more experience than we do. That's their expertise. Current workforce capacity, given increased pressure and reduced reimbursement for most of our organizations, simply we don't have staff to do it or don't have the time to do it. What about objective view? As employees, we're all invested in our organization, and that's really a good thing. However, we may have an inherent bias in our current operations, and a fresh set of eyes may reveal opportunity that we haven't seen. It's not that we've got the blinders on. We're just comfortable doing what we do. Here's a protocol. It's working. Why should I do something else? Well, maybe the consultant has one that works better. Politics. Don't talk religion. Don't talk politics, and I'm not talking about either. I'm talking politics, little p. Now, political parties, little p politics. And the reason it's a big P here is for consistency on the slide. We may see the world through the lens of our department rather than the big picture. Now, you've heard me talk before, is we want to optimize respiratory therapy services, but not at the expense of hurting or slowing down another department, nursing, pharmacy, or whomever. Secondly, departments may be managed differently depending upon the viewpoint of the executive in charge. Consultants must acknowledge these internal politics, but they're not bound by them. Their analysis and recommendations aren't determined by internal politics. And let's just take a minute so we're not talking about the big P politics. You may report to a director of outpatient services. That individual may have a different view of that, their bias may be that outpatient is more important than inpatient, and respiratory therapy in your department is 99% inpatient. Or you may report to the vice president of finance who their personal viewpoint, their bias is cost effectiveness, less so safety and quality. Not bad people. They're not right. They're not wrong, but their perspective. So think of perspective. Maybe it's a better word than politics. In fact, I'm going to change the slide after this presentation. Enhancing accountability. Frequently, consultants see that accountability varies night and day, particularly between departments and service lines. Consultants see this, they're able to assess it, and they can make recommendations to ensure consistent accountability. So enhance accountability so that it's consistent. Speed to achieve results. For many of us already working 60, 70 hours a week, there's not enough time today. We simply don't have the time. Consultants are able to accomplish the work efficiently because they're bringing more dancers to the dance. So when a consultant company comes in, it could be one or two, it could be one person, but it could be 40. And I know some of my friends in the consulting world, who all of them worked in the hospital, said, you have no idea how things work on the outside, kind of the dark side they refer to it as privately. When you have no consultants one day and 40 on site the next day, that's person power that you just don't have in the hospital. What about speed to achieve results? Again, we're working a lot of hours. We just don't have the time. And having that extra labor who has more experience, has greater expertise in the whole, makes sense. The last one is kind of that icky one. The consultant may be brought in to implement something that the board or the CEO already wants to do, has already planned to do, but knows it's not going to go over well. If you close your eyes, I bet you know something that should be done in your organization. So do that right now. Man, close my eyes. I can't believe we still have that same schedule. When it gets posted, there's 2 vacancies on Thursday and there's 7 on Friday. Why are we doing this? Why are we doing this to ourselves? But have you talked about that with someone in a constructive, positive manner? Is there a way that we could create a schedule that's more balanced? If we've got holes in the schedule, we've got holes in the schedule. But 2 on Thursday are going to get filled a lot faster than 7 on Friday, at least in my experience. The problem is it's uncomfortable, or in some cases, career limiting to state this. Consultants don't have to live with the decisions. They can cut through this and recommend action, even if it's unpopular. Hey, Gary, I noticed in working with you and talking with your staff, you've got holes in your schedule, like many do. But I noticed in looking at the last 3 months, when you post a schedule, you have far more open shifts on Friday than Thursday because the weekend. You know, I get it. What that's caused is an inordinate amount of overtime because someone works the weekend, maybe working Monday, doesn't want to work 4 12s in a row. Let me help you create a schedule that's more balanced. I'm all over that. So here's someone that just gave me the answer in a nice way, didn't give me the beat down as a director, so to speak, didn't put it on his report card, didn't know how to do a schedule. Here's something for your consideration. So we work together, and guess what? I'm going to be more accountable. I'm going to have more objective review, and I just increased my personal expertise. So what are the typical focus areas? And these are in no particular order, but quite honestly, when I talk to my consultant friends that work for these big companies, the big 4, 5, or 6 or whatever, it is cost savings. That's number one, and ain't changing. Labor, non-labor, and care variation. Let's just pause in that. They're going to look at the labor. They're going to look at non-labor, and that's capital, devices, supplies, equipment, PM, etc. And they're also going to look at care variation. Are you using evidence-based medicine? Are you practicing at the highest level of clinical evidence? Are you assessing the respiratory therapist adherence to patient assessment and making changes in the care plan? Labor, non-labor, care variation. Cement those in your mind. An easier way I look at it is it's staff or stuff. Staff is the labor, stuff is everything else. Again, just my words. Clinical operations. What do you do? How do you do it? So what do you do? Are you practicing evidence-based respiratory care? How do you do it? Do you have protocols and pathways and patient assessment tools? All of us can deliver an effective nebulizer treatment, but are we using the most effective nebulizer? All of us can put a nasal cannula on a patient, but are we using the softest cannula that will reduce red marks in the face? I would hope so. I know otherwise. The last is, what do you have to show for it? so that let's use the cannula. You had a hard cannula, you switch to a soft cannula. Cost a nickel more, I'm making up the numbers, but just for our purposes. Who wants to spend a nickel more when you use 80,000 of them? Finance doesn't want to hear about it. But so let's say you take a look at the red marks on 30 patients with the hard cannula after, let's say, you pick a 3-day period. And then you switch to the soft cannula, do the same thing. Simple quality assurance project. You've heard me talk about state and national meetings and perhaps in other webinars. Now you know what? So if the amount of red marks go down, which by the way is a reportable event, so it's a safety and quality issue, that's what you have to show. We spent a nickel more, whatever the sense is, and look what we got out of it. Fewer red marks and faces. Compliance. Not the compliance office. Absolutely look at that. But compliance to services, just like the Joint Commission or whatever deemed survey group that your hospital uses. They ask you very simply, what are you doing? Show me the policy and show me that you're adhering to it. I've never heard a surveyor say, don't do it this way. We do Q4, do it Q2. What are you doing? Why are you doing it? Show me how you're adhering to that. So that's compliance to the policy. And I'll use patient ventilator assessments as an example. I'm not aware, and in fact, I'd be delighted for the folks listening to this live and on demand to contact me, gwkaufman@hotmail. You can find me in AERC Connect. If you have any information that you can help educate me as to all the stuff that I'm talking about in the webinar, plus things like Joint Commission or other deemed surveyors. But my experience is they don't tell you to say, we're doing Q4 patient ventilator assessments. And please don't call them vent checks. That's just the wrong word. Please do our profession a favor. Stop calling them checks. They're not. They're patient ventilator assessments. And if they ask you checks, in fact, you say politely, I think I know what you mean. We assess the patients. We assess how they're doing compared to the ventilator settings, and we make adjustments. And that's PVA, or patient ventilator assessment. They're not going to say, hey, you're doing Q4, you need to Q2, because there's no science to that, at least to the best of my ability. But should they say, hey, you're doing this, and you could be doing this, ask for the literature nicely. Hey, be happy to make the change. We're always looking for help. Thank you so much. Matter of fact, anything that I find in this regard, I'll send you after the engagement. Man, 2 home runs. Human resources, we know we're talking about here. This is efficiency, productivity, whatever you want to call it. Span of control, all that is critical because human resources in most organizations are 50 to 60 or even more % of bottom line costs. Physician alignment. I don't mean whether they're employed or not. I mean, are the physicians aligned to hospital operations? Who pays them? How they get paid isn't the issue. Are they aligned? Are they active in value analysis committee? Are they active in quality assurance committee? Are they active in looking at staffing productivity, particularly your team medical director? Rev cycle, absolutely top 8 list. We need to optimize reimbursement for what we do, even if it's being paid in a capitated system, such as DRGs that most of us are. Look at strategy and also look at technology and implementation of technology. And that's probably less so respiratory therapy than you'll find in imaging and maybe radiology and even pharmacy, perhaps. But I'd suggest that for every piece of equipment that we have by type, invasive, non-invasive, high flow, et cetera, that we have validated citations to show that we're using that appropriately. Again, internet's a wonderful thing, can be dangerous at times, but if you don't have it, you can probably find an AERC Connect. Again, if you're not an AERC member, I encourage you to be one. Yes, I'm a former president of the AERC. That's not why I'm saying it. It's the best bang for the buck for 25, 30 cents a day, whatever dues are, they're insignificant. You want something, post on AERC Connect. Hey, I'm looking for a career ladder, a clinical ladder. You post, I guarantee you're going to get answers in 24 hours, sometimes 1 hour. So if you have a question about technology, post on AERC Connect. So just to reinforce these areas, This is what, from my experience and input from my consulting friends, this is what they're looking at. So why, where, when, who? Let's talk about this. Things you need to know before the consultants come. Why are they coming? What data information will they require? What else do I have that I want to share? Who is the consultant that's going to be in my department, if known? For RT department, these three areas, care variation, labor, non-labor, that I talked about in a previous slide, are always important, along with efficiency, productivity, standardization, clinical services, span of control, and administrative versus clinical FTEs. So one of the things you'll want to be prepared to have is your organization chart that shows by position, doesn't have to be the name. Here's a director, we have 2 managers, we have team leads and frontline therapists. How many FTEs are in each of those positions? And I promise you, if you do this, you're going to really look in the eyes of the consultant. What percent of each of those positions is fixed, administrative, I'll call it, or clinical? So let's say you're department director, you're 100% administrative. Fine, write that down. On the organization chart, RT department, 100% administrative fixed. Team leads, I have 6 FTEs. They're 50% administrative, meaning fixed, 50% clinical. The consultants ask for it, so why not prepare that before they get there? The last, and we'll look at these in more detail in the slides forthcoming, but knowing who the consultant is, LinkedIn, Google, AERC Connect, and other ways, even Facebook, perhaps. Look them up, scope them out. You'll be better prepared. So why hire clinical consultants? A couple of slides ago, I talked about other things that consultants do, other services they provide, rev cycle and strategy. But I'm going to focus on clinical consultants because for the most part, that's who we're dealing with. I've been on the other side of the table as the consultant. I can say this. I've been on the other side of the table, have consultants who are physicians, nurses, straight out of MBA school or MPA school or MPH school, and don't know a ventilator from a bedside table. Not that that's bad, but you need to know. As they're interacting with you clinically, if they have no clinical background, we need to prep for that. They can be a wonderful resource, or they could be your worst nightmare if you use jargon and maybe even try to smoke them with some of the things. As they hear that, feel that, it's not going to go well. So why do we hire clinical consultants? Effectiveness, procedures, devices. Efficiency, we need to be clinically effective and do so in an efficient manner. Value efficiency, that I attribute to Rob Chatburn, brought this concept up years ago. Rob and Rick Ford and I wrote an article published in Respiratory Care. I think it was December 21, but I may have missed a year or two there because of the pandemic. Wrote an article on value efficiency. What is it? Value efficiency is simply providing evidence-based respiratory care in an efficient manner. That's it. Let's break that down. You can be efficient. I can do 40 treatments a shift, but if 20 are not clinically indicated, I'm not effective. In fact, I'm wasting time because that time I could take, I could cut out that time for non-needed services and paste it in something that would add value. Mobility, proning, discharge phone calls, amplifying your point of rehab program, starting a disease state management program. So cutting waste, pasting into value makes you more effective and more efficient. Collaboration with, less so within a department than with between departments as that external consultant. They're looking more at how does nursing and respiratory and physicians collaborate, maybe pharmacy and lab and imaging as well. They've got standards. I don't mean personal standards. They know the standards like the back of their hand for Joint Commission, your Department of Health, for other leapfrog and other benchmarking services, they know it because they buy it. They know far more about this than I'll ever know. And knowing that, I want to utilize this engagement to learn about that. I know you've worked with Institute for Healthcare Improvement, and I saw your name on LinkedIn about something you did. Now, what did I just do? They know I looked them up, so they know I do my homework. It's not about me looking them up, scoping them out. It's the fact, hey, he does his homework. I need to keep that in mind. So that gets you to, I think, the first base right there. Secondly, you just said, hey, I can certainly learn from you. And I'm not talking about sucking up or whatever. I'm talking about acknowledging that in some areas, I know more than you, the consultant, particularly these are not respiratory therapists. There are some things that I have more experience with. I wouldn't say I know more than you. Some areas I have more experience with. And I'd like to show you a couple of our protocols and really get your feedback on this. Medical director. If you're not tight with the RT medical director, job one, get tight. The RT medical director can be the person who makes or breaks an engagement. If that consultant gives you numbers that say you're not hitting the benchmark for efficiency, clinical productivity, you need to cut 20% of your staff. Not unusual, by the way. And your medical director said, ho, let's get together and we'll show you our productivity system and we'll explain, things that are unique to our organization that you may not be aware of, and we'll show you the math. This is how we came up with the patient demand, the next bullet point, and our staffing plan to meet that patient demand. And we need to show you a document of our fixed staff. So when we look at productivity, we base the therapist in NICU, in PICU, we have one-to-one ECMO, and we base the therapist in the emergency room, emergency department. Those are all fixed, not associated with clinical productivity. So you're paying a therapist to be in the ED, and she may be 60% productive, but that's not the reason that productivity isn't the final determinant of her value. It's the fact she's there to intensively care for those patients who come in, and for some of them, not admit them because of great respiratory care. Patient demand should not be counted in the number of procedures. I'm going to repeat that. That's not a valid productivity metric. If the consultant shows you, again, be nice about this, that you need to do a benchmark of 5.12 and you're at 2.76, that is meaningless. Keep this between us. That is meaningless if they're not using an intensity of service productivity metric. And what do I mean by that? AERC Safe and Effective Staffing Guide says you get 15 minutes for nebulizer treatment. And that's door to door. That's not just for the treatment itself. 15 minutes. That's it. That's a validated number that's been in place, that system in place for over 40 years. That ventilated patient that you care for, you may spend 2 hours for each ventilated patient. And I would say, how much time do you spend for a vent? Nothing. I spent time with the ventilated patient. So if you spend 2 hours with that ventilated patient on your shift, and that consultant counts that a 1, and the nebulizer treatment is a 1, you're in for a world of hurt because that's not validated. KPIs, key performance indicators. Hey, what's the benchmark out there? Or best practices, or leading practices some use. When they say, here's the labor hours per unit of service, and it's a number, show me the math. Politely, if it is worked hours per treatment count, simply not valid. Here's where your medical director can come into play because her productivity is measured on RVUs that are nationally validated through CMS and AMA. So when I go to my doc for my annual wellness visit, or even an extender, I'm a level 1 visit. And let's just say that's 7 minutes. That's productivity. When that patient just discharged from our hospital, or I should use the term transition from the hospital to home, is next to me, that's a level 5 visit in this example, and maybe the provider gets 45 minutes. Let's do the simple math. How many visits is that? 2. Are they equal? No. One's 7, one's 45. What's the total amount of patient demand? 45 plus 7. So that physician gets 52 minutes of credit for that. They're not based upon 2. Best practices, I have found, is a good place to use your ears rather than your mouth. I'm not necessarily good at this, but trying. Ask them, I'm really interested in information you've gotten from other engagements. We believe that we've got a good, solid ventilator liberation protocol, but I don't know, I think we could do better. Do you have any articles or protocols that you can share? What have you accomplished? Acknowledged you don't know it all. Stated you're humble. Stated they know more than you do in this area. You're already in third base. And now you bring it home is the rest of the lecture. So who's coming to you? Are they clinical, non-clinical? What's their experience and what's their track record? And you may not know this for every single individual. It may be company X is coming to do it, and you don't know who is going to be the consultant in your area. But ask around. Use LinkedIn, AERC Connect, and say, hey, consulting company X is coming to us. Anybody like to share their experiences, either publicly and connect, or here's my personal information. It's really important to know who you'll be dealing with. That's your prep. Every sports team goes into every game knowing who the opponent is and whether they know I'm going to be matched up against this guard and he's really a tough guard, or he likes to shoot 3-pointers, or whatever the case might be, or he has, his ankle's kind of gimpy. Preparing is important. That's what gets you to I shouldn't mix my sports analogies, but gets you to the batter's box. So, focus areas. I've said it before, I'll say it again. These are typical: clinical services and care variation, labor and non-labor. I've said it before. Want to simplify? Staff and stuff. I'm going to look at each of these individually because this is critically important. Yes, you need to know these 3 areas, but we need to dive into each of these, and I'll share my experiences and my knowledge I've learned from just listening to consultants, not just, but listening to consultants and applying that so that our department is better prepared. So what are the typical things they're going to look at? And I'm going to spend a couple minutes on this because this is the core. So eliminate unnecessary processes. By processes, I don't mean just the breathing treatment. I'm talking about other things that you do. Let's take an example. Back in the day when hospitals were paid on a fee-for-service basis, we did oxygen rooms. I remember them vividly. We would go by, stick our head in the room, see that the oxygen was bubbling because we use humidifiers because we didn't have science to show that they don't add value, at least at low flow. If it was bubbling, I'd write down 8 because that meant the shift before me wrote down an 8. The patient's on it. I'm going to charge them for 8 hours of oxygen. That's not how it works anymore, with some exclusions for fee-based hospitals like Children's, Government, and Critical Access. There's some differences there. But we need to replace, the vast majority of us replace oxygen rounds with oxygen management. Not is the oxygen flowing, but is it the right amount? Is the patient on a different amount when they're walking as per your assessment and prescription? That's the stuff behind the scenes. That's support activities. Eliminate non-valued care. If we're doing procedures that have no scientific validation, we simply just stop. Now, I don't mean tomorrow. I mean, tomorrow I have the talk and get a plan to stop it. As an example, 2011, I'm sorry, the AERC clinical practice guidelines for incentive spirometry stated that the routine use of incentive spirometry has not been shown to add value for those patients that can take a deep breath and have an effective cough. 2011 clinical practice guidelines from the AERC. Is there evidence Question everything. Is there evidence what you're doing should even be done at all? Is there any clinical indication for it? Is it scientifically validated? If not, let's make that the plan. Evidence-based practice, we've really got to pivot from custom. This is how we've always done it, to evidence-based respiratory practice. It's essential to communicate this to the consultant. And I used the example of Q4 patient ventilator assessments. Is there science that that is better than Q6 and Q8, worse than Q2? I'm not aware of it. In fact, if anyone listening to this live or on demand is, please email me, gwkaufman@hotmail.com. Again, you can find me in AERC Connect. Please tell me. I just don't see that we need to be doing, we should not be doing things just because we always did it. Patient-focused respiratory care protocols or short-term protocols. Studies have shown a decrease from anywhere from 5 to 20%, and even some higher in bronchodilator treatments once a validated protocol was implemented. Consultants know this. If they're looking at respiratory therapy, they should know this. They're going to present it to you and say, what evidence that you have? You've been monitoring the clinical indication of an order, whether physician ordered or extender or protocol derived, and show me how you've modified that care plan as the patient condition has changed. COPD patient comes in Monday morning, Q4 bronchodilator. Seems like a reasonable order. They're sick enough to be admitted. They're going home on Friday, it's still Q4 bronchodilator. That can't be. They're going home to nothing. They're going home to a maintenance medication, or maybe once or twice a day breathing treatments. Q4 is not the answer. And they will expose you, and should, if we're not using evidence-based practice. Standardized care processes for similar conditions. And this is really where pathways or care plans or care maps, I think that's a trade name, but pathways are important. It's critical that our services are embedded, integrated within those care plans or pathways. Contribute to care coordination. There's increased pressure to reduce expenses, both for the hospital episode, utilization of navigators, enrolling COPD patients, point rehab, and transition. So how do we contribute to that care coordination? Protocols for inpatient, transitioning that patient to the medications they're going to get at home while they're in the hospital. Yes, you're saying, Gary, I know that maintenance medication, that's what they're going home on, but pharmacy or administration or my boss doesn't want to pay $200 for that medication. It's the best money you can spend, and science shows it. Patients who are going to become people, real people after discharge, who have adequate education and return demonstration that they're using that maintenance medication, that inhaler, that DPI or SMI, appropriately, don't come back to the hospital as frequently, in 30 days at least. That's the goal. AERC, Safe and Effective Staffing Guidelines, says you get time to do patient education. And I'll suggest that that's not just a one-off. Patient comes in on Monday, going home on Friday. Maybe Tuesday you start the education. Wednesday you start them on bronchopulmonary hygiene care, general care. Wednesday you bring in the maintenance medication device, the DPI SMI. You teach them how to use it. You show it to their significant other, if there is one, that would be a plus. And then Thursday, they show you how they're using it. Friday, you do a quick check, wave them goodbye and say, love you, I hope I don't see you for a long time. That's care coordination. The outcome is better quality of care, improved clinical outcomes, maximize use of our knowledge, skills, and competency, and quite frankly, shows why they need us on the team. So what about labor variation? The only valid statistic to accurately measure clinical productivity is procedure times that account for the intensity of service. I said it earlier, a nebulizer can't count as a 1 if a ventilated patient day counts as 1. It's got to be validated. Only the AERC SESG methodology, which, by the way, has been validated for over 40 years. That's it. No other system has been validated. It's important to show that you staff to volume, meaning patient demand, and how you flex. So you need that productivity that's validated both to look retrospectively. How did we do last month for productivity? Our target's 85%. Did we hit it? Were we over? Were we shorthanded? We missed procedures? Did we have call-offs? What's the percent of, or what's the hours or percent of call-offs or overtime or agency use? And then prospectively staff, if this is what we did in the month of February last year, is that reasonable to project it for next year? So when you're putting the budget together for the department heads, you can use that. That's science of labor management, and will demonstrate that you understand this and you understand labor variation. Now, staff to volume based upon demand. Volume meaning patient volume predicated on a validated productivity metric like procedure time. How do you do it? Are all your staff full-time? If so, you can't flex as easy as if you had a certain percent of your staff in a flex position. I don't have science for this, but I've seen in my career a target of maybe 20% of the total worked hours be in a flex position, PRN, part-time, weekend option, whatever they might be, as a means to reduce the reliance on overtime. By the way, just between us, overtime is not a bad thing. It's an indicate. It needs to be looked at how you apply it. If a department never has overtime, I got a question: are they overstaffed? Maybe they're just the best they've ever seen. So I just don't see 0% overtime or 0 hours overtime. Can you show how you use it and you're using it judiciously? 2018, 2019, I talked with some consultant friends on behalf of a project we're doing with the AERC. What's your front burner? And the front burner was not what it used to be. Front burner used to be decrease clinical staff to hit productivity targets. Still on the stove, front burner is reduce middle management. So what I'd suggest to department heads and managers is to look at what are there opportunities to assume management of other departments, particularly as that manager leaves. So the manager of sleep retires, there should be a plan for you to talk to your boss. Before that, hey, if any of these other folks retire or leave, I'm prepared to take over the management of that area. Love to hear it. Revise your workflow in response to the above. And this sounds like an easy one to say, but within your EMR, as you have the ability to capture everything that you do clinically at the time of service, you're going to be way ahead of the curve. And there are a handful of departments that do this. Actually, in the new 2025 edition of the AERC Safe and Effective Staffing Guide, you'll be seeing more of this to show you how to do it, stepwise how to do it. But today, certainly work with your IT and finance folks. Is there a way that we can capture activity at the point of service? I do a nebulizer treatment. I click, I did it. It drops 15 minutes. Productivity is captured. I go to a Code Blue. I come back 1 hour later. I click 4 units of 15 minutes. It's captured. So the goal of all this is to show that your resources are aligned with the needs of the patients and the organization. Now, non-labor variation. It's important to standardize process and products for supplies. I want to reinforce this. The goal is never, ever, ever, ever to buy the cheapest thing you can get your hands on. The price you pay up front has no relationship with the value that it provides. I mentioned, you probably heard me speak about hard salt cannulas. I can buy a hard cannula for a nickel less. I'm not going to buy it. Why? Not that I don't want to save a nickel times 80,000 patients over the course of a year. That's a lot of money that we could save, but a hard cannula makes more red marks. That's a reportable event. And it's not doing the right thing for the patient. Maybe simply using a softer cannula, effective nebulizer, a heated wire circuit, all of which may cost more upfront. And that's what the second bullet point is talking about. Look at the big story. Look on efficacy, and not acquisition price. If you have the opportunity to buy a 1971 Ford Pinto or a brand new Ford whatever, would you do that? Not to pick on Ford, by the way. No, I want the safer device. If I can afford it, I'm not going to buy on price alone. If I do, our patients will suffer. Coordinate with pharmacy to evaluate medications in terms of standardization, unit cost, and overall cost, including labor. And I'll give you a real simple example. One person I talked to just last week called me and said, Gary, could use your help with our productivity system. I said, great, let's schedule time. I'll help you with it as a friend. As a volunteer with AERC, actually, and a friend. And she said in her hospital, they want to switch from inhalers to nebulizers. And I won't name the other department, but it was not respiratory therapy. And I said, well, let's just get a piece of paper out, pencil, let's work this out. The unit cost of a puff with an inhaler versus inhalation with nebulizer is not the issue. We got to look at labor. So whatever that little machine that you use, that inhaler costs, you have to look at the labor. And if it's an MDI, you need to include the cost of the valve holding chamber. It may be less expensive to do it in the whole, but switching from an inhaler to a nebulizer without considering labor, is short-sighted. Standardized capital equipment. Again, I never talk brands this. And not saying one device is better than another. I'm saying there is cost savings to be had if you can have one ventilator brand or two ventilator brands rather than 5 or 6. Why? That the stock as much supplies, the QC, the PM, the biomed time. So what's the outcome of all this? The outcome is more efficient care. So I'm going to spend a couple of minutes on this. How can you contribute to a successful consulting engagement? This, if you're taking notes or you're doing screenshots, I'm just going to pause. I'm going to get a sip of water. This is one of the most important things that we need to do. And quite frankly, I haven't done a very good job in the early part of my career. Hopefully it got better through the years. But I take a look at this list, and it's my planning point. First is cooperate. Don't argue back. Cooperate. Get what they say, bees to honey and all that, you'll get more cooperation. You will end up looking better if you cooperate than you fight. You might be right, but don't fight with your right. Provide your expertise, as I mentioned before. Provide data. So you know they're going to be looking at staff and stuff, labor and non-labor, and operations. Get the data. If you don't have it, we should have it today. What is the cost to RT direct labor cost to fulfill 100,000 hours of patient demand? We should have that. What percent of that cost is overtime and why? What is the cost of turnover in your department? What is the cost of getting a rookie, a new employee up to speed? There's some data out there, not a lot, but I looked to the nursing literature. I remember the one I read 20 years ago now, I guess. The cost to replace a seasoned nurse was on the order of $60,000 to $70,000. That's probably $80,000 to $90,000, maybe even more than that. I don't have accurate data, at least if you have it, please send it to me. I don't have accurate data on what it costs to replace a respiratory therapist. Let's just use nursing as an example. We may make 15, 20% less than nurse. Let's say the turnover cost of a respiratory therapist is $60,000. That needs to be accounted for. And every time a therapist leaves, and not that it's in your control, though could be some, how they're treated, use of protocols or whatever, but every time a therapist leaves, you just spend 60 grand. And that's the data that the consultant's going to show you and show your boss, so we better have it before you. Correct any incorrect data. I see it 100% of the time, not 99, 100% of the time, incorrect data. Well, I compared your department to the benchmark. and your executive has said that you need to hit the 25th percentile. You're at the 50th percentile. That means that you have to reduce 20 of your staff. They're just not coming in and say, hey, you need to add 6 staff. They're coming in and going to show you data that shows that, not 100% of the time, but the vast majority, you need to reduce staff. And here's the data. Question everything. Here's our productivity system based upon a nationally validated productivity metric that's been in effect for over 40 years. We base our staffing on patient demand that's calculated by every procedure. It has a validated procedure time. I'm talking fast because I've said this 1,000 times, so slow down. Validated procedure time, and here is our results. We are hitting our productivity target. We've reduced that target by 5% because we have fixed positions in NICU and PICU, and they are not able to hit the productivity target that's predetermined with approval of your medical director, finance and budget, your COO, med exec, whoever that might be. Get this, and I'm clapping my hands here, get this down before they come to the door. It has saved a lot of grief. Recommend innovative ideas. Hey, I need your advice on something. Here's something we just started doing. I'm not sure we might be missing something. What have you seen in another place? So that's what you're going to have live. You need to plan the discussion. And maybe it's a couple things. Act before they tell you to. If they say, hey, I'm going to recommend a 90-day plan to implement this protocol or this new process, not protocol, this new process, knowing that's going to be in the final report, come prepared with your action plan. And not to say I can do it in 10 days less. That just may be a smart aleck response, but here's the action plan. The consultant recommends a 90-day plan to implement this revised process. Here's the timeline, phase 1, phase 2, phase 3. Here's our goal. Here's how we're going to measure it. Here's the reporting system that I set up with information technology. If you look good in front of the consultant, you certainly look good in front of the boss and other department managers. Demonstrate, I want to be held accountable. As we're putting this new process together, I've not been looking at, are the therapists adhering to the patient assessment device we have? Now we are. Thank you so much. Would you mind if I call you in 6 months and report this to you? I could really use your help. And use it as a way to grow. Efficiency, and I talked a lot about this, so technology, tools, optimized charting, streamlined charging processes. When I say charging, not necessarily that it generates revenue, but how you drop the charge, and in particular, how you capture productivity, and use the best supplies, best devices, and best capital equipment. Again, don't buy cheap. Your patients demand more. So let's talk about staffing. That's the proverbial elephant in the room that many times consultants will say, I want to talk about this, safety and quality. They're going to get to this. And this is number 1. So your scheduling process and the technology that you use. Percent full-time, percent flex. How you staff each shift, days, nights, and weekends, maybe holidays and spring break and other. The seasonality of staffing. They're going to ask for that. You have 10 on days, 10 on nights. Monday through Friday, same 10 on days, 10 on nights on the weekend. Maybe that's not efficient. If you have a validated productivity system that says it's 10 on days, 8 on nights, and on the weekends, since we don't do hearts on Friday, we drop to 9 and 7. I'm just making up these numbers off the top of my head. Show them how you flex to patient demand. They're going to be taking notes. This person knows what she's doing. Sue's got it together. Percent administrative versus clinical span of control. For those of you who don't know what that is, that's how many people report to you. That, I don't know if there's a standard. I've heard some people say it's 20 to 1 or 25 to 1. I'm not sure that's validated, but they're going to give you a number. And if you've got, let's say, a department director, and you have 2 managers that report to you and all the staff report to the managers, that says right or wrong, I would deliver that to them and also say, as the director, I am also responsible for all the clinical staff, because they're going to plug in a 25 to 1 number They're going to say you have too many administrative positions. Job descriptions, clinical ladder if you have one, and maybe you don't. How do you make adjustments to staff? And how do you balance the schedules? What is it that you do? What's the technology? What's the process? How do you measure? So looking at efficiency, staffing, and patient demand, now we're going to focus on patient demand. How is it calculated? Use the AERC system, you're good to go. What is the current demand? Do you capture only charged procedures, or do you also capture non-charged procedures, or those procedures that don't have a CPT code? We've got to get them all. Code Blue, rapid response, prone, mobility, transports, none of those have a CPT code, at least to the best of my knowledge. But it takes a little bit of time or a heck of a lot of time. We've got to be able to have our system capture that. Or guess what? You're going to look like you're overstaffed. Capture of unplanned and variable services and charge master. Do you review it? Do you update it? So let's look at standards. Use a standard. Joint Commission, the Department of Health, IHI, other sources. The AERC Safe and Effective Staffing Guide is the only validated system to accurately measure clinical productivity, period. If you're not using it, I encourage you to secure it. I don't know what it costs, the AERC charges, whatever the amount is. It's pennies on the dollars that you will save for a consultant that doesn't use this to say you've got to reduce your staff because a nebulizer is one and a ventilated patient day is one. Nonsense. Don't use those words again. But what procedures you counted and how are planned and unplanned variable time services collected? I just mentioned Code Blue. Go to Code Blue. I'm there for an hour. Sue's there for 2 hours. I come back. I put 4 units of 15. Sue comes back. She puts 8 units of 15. We captured our time. Doesn't matter whether it's charged or not in terms of productivity. It does matter whether you capture it. If you've heard me speak, you've heard me emphasize evidence-based practice, practice at the top of your license, use the best available evidence, and patient-focused respiratory care protocols are the package to do it. You want to show which protocols are in place. You want to look at physician acceptance. Well, we've got protocols, but docs don't really want to use it. They like writing orders. I call those one-offs, just my term. Why is it? When your medical director has talked with that physician who always countermands the protocol and writes Q2 bronchodilator therapy, well, has your medical director done that? Have you and your medical director had that conversation? A good friend of mine, Ken Thigpence, introduced me to a book, Crucial Conversations, one of the best books I've ever read. Get it from your library or buy it. If you don't like it, I'm sure you will. When you had that crucial conversation, Sue, medical director Sue, we have 80% acceptance of our protocols, 80% of physicians, but we have 2 physicians that want to right there. Can you talk with them? That doc to doc is more likely to have a change in behavior than if you or I do it because we're not docs. Are we doing adherence and compliance audits or QA studies? Audits, sometimes people don't hear use that word, but it's an audit. Are you assessing adherence and compliance? Not compliance of the physician ordering appropriately. That's what I talked about, second bullet point. Are the therapists adhering to doing the patient assessment and changing therapy frequency and modality based upon your system? You don't need to invent them. Google it. There's a ton out there. I think there's probably 100 just on aerc.org. And what PDSA or PDCA process do you have in place to show you're looking at it? Collaboration, multidisciplinary team. We accomplish very little individually. And I mean we, nurse, the doc, pharmacist, respiratory therapist together, a lot more. Medical director, if they're not aligned, job one, gotta be. Do they understand protocols? Do they understand the productivity system? Do they understand why you put 4 vents in the budget and didn't get any? Well, maybe they can help get them next year. Who are the physicians? Are they hospitalists, intensivists, pulmonary critical care, infectious disease? If I were going to Value Analysis do a presentation on a common canister, one of the 20 stakeholders that I will have talked with prior to that presentation with infectious disease, because I want her to understand that common canister, as the protocol we're using, evidence-based practice, is not going to increase passing bugs from one patient to the other. Nursing council, integration, collaboration. The biggest department in every hospital I've been, nursing. Get in line, good partners. And I mentioned, I use rounding is if you're standing in the back of the room and waiting for someone, wait for the doctor to tell the nurse, hey, tell respiratory to change the rate from 10 to 8. You're not a leader. You're not doing your job. Our team medical director needs to be engaged. Not that employed or not, doesn't matter. They need to understand basic operations. They're not going to be able to do the schedule for you. Although, wouldn't that be cool? But show them how you create the schedule and how you adjust it. And the issues with call-offs and other issues with send homes, why you do it. They have the influence with physicians and nurses that we don't. That person, Medical Director Sue, is your face to the medical staff. Not you, not me, your face to the medical staff. And engage them to do medical education or do respiratory therapy education. So I found in the past, I'd ask my medical director, hey, 4 times a year, can you do a 30-minute in-service? Never heard no, that they wouldn't do it. Hey, is there something else I can do? What happens? That person invites you to give a presentation to the third-year fellows on ventilator liberation protocol. So it works both ways. They're going to look at best practices, and they want to make sure that the policy is prescribed written guidelines and are followed. Are the protocols monitored? Not just I have one. And are the outliers reviewed by Sue, your medical director? The gold standard for respiratory care includes alignment with AERC standards, policies, white papers, position statements, current evidence-based medicine, and peer review journal articles. Not something you pulled down from the web last night and says, hey, this thing is better than another thing. Well, what are KPIs? And we're heading down about the last 5 or 6 minutes. They should be co-presented by the RT director and medical director. This is your report, your scorecard, your dashboard. KPI should be on the agenda for every single meeting. Here's the 2 things we're doing for safety, the 3 things we're doing for quality, the 2 things we're doing for cost effectiveness, and the 2 things we're doing for patient engagement. That should be hardwired. Your medical director should play a role. That should be given to the consultant. I even like, if I know the consultant and I have the permission to provide information to them before they come. Again, underscore, if I have the permission, I'm going to fill up their inbox with all the good stuff we're doing. And I'm going to ask, if you have a couple of minutes, take a look at that protocol. There's just something, I think there's something we're missing. When we get together, I really want to learn from all that you know, having worked with other departments. So what are the drivers? Did I say it 3 times? I'll say it twice more. Engage medical director. Engage medical director. Doesn't matter if they're paid or not. I don't think it matters the discipline. Many others disagree with me. That's cool. Is a pulmonary medical director maybe more in tune than someone who works in infectious disease? Yeah. But you're utilizing them, you're collaborating, you're co-presenting with them as a physician. I would rather have, here's a Gary opinion statement, I would rather have an engaged medical director who's Ahmed than a pulmonologist who just comes around to sign the PMP each year. They are critical. You also need a champion administration. It may not be your boss. It may be the chief nursing officer, maybe the chief finance officer is really impressed with your pathway that you've driven down length of stay. Doesn't have to be your boss. Cool, you want your boss to be your champion, but it may be someone else. Your decision-making needs to be done based on data. No opinion, no custom. I think we did pretty good this on data. Effective communication, 2 ways. Again, 2 ears, 1 mouth. Use them in that order. Steadfast willingness to advocate for patient safety and quality. The reason I used a lot of words for this one is steadfast. We don't do anything if it harms the patient. We start the day with patient safety. We end the day with patient safety. Everything falls in place after that. And a culture of education and advancement. I'm going to go through some sample reports, and these are dummied up, certainly. But I'm going to pause on this slide, then I'll show you a few more. Here's a report, and here are the four focus areas: staffing or core staffing, vacancies, retention, and recruitment. An experienced consultant will always look at these and will always ask you, how do you do it? What is your core staffing? How do you handle vacancies? Do you have an on-call? What is your employee retention? What's your turnover? How many days do you recruit and educate a new employee? Core staffing, vacancies, retention, recruitment. Trust me, it's not a cute acronym, CVRR. Trust me, this needs to be in your prep. And if you got it and show them that, you got them. So for core staffing model, here's some right off a report. Current staffing model does not provide staffing to the patient demand. Current productivity system does not account for all patient procedures and services. Doesn't count for the non-CPT coding. It needs to. Doesn't have enough flex positions. They're 99% full-time and they can't flex. And they just use 12s without thinking. They've not even thought about looking at 10s or 8s or 4s or whatever. Another on vacancies, consistently, there are 10 to 12 vacant positions. This is 2017, by the way. I got this off a report a friend sent to me. The RT administrative position is frozen or eliminated. It's a true story. The director retired and it was decided we don't need it. That needs to be addressed before they come in. But this report said that if the director isn't there, I'm recommending freezing that position until further review. You don't want that to happen. You do not want to get to this point because they're rounding third going home on that. And your executive may say, you know what? We don't have to replace that. The consultant said, we can combine that department head with another clinical service. RT educator and RT navigator positions are approved, but the job description. So this is a slap in the face to you, to me. They approved, but they don't have the job descriptions approved. That's on us. This cannot be in a report, and it's verbatim from report. Turnover is just horrible. That's the words in the report. I clean it up for this presentation. Turnover percent exceeds area hospital department. Your turnover is 35%. Hospitals in the system across town is 8%. You're not an effective manager. You're not an effective leader. On retention, wage and benefits are not consistent with area competitors. Now, that's a good thing to see if you're an RT director and you've been trying to get more money for your staff. Recruitment sign-on bonuses doesn't retain staff. Hasn't, won't, will never. Sign-on bonuses gets them in the door, doesn't retain them. All the rest that happens is on us. Recruitment sign-on bonus is a disincentive for current staff. A knowledgeable consultant will talk with staff and say, hey, I saw you guys have a $10,000 sign-on bonus. Did you guys get any of that you're already here? And they're going to get an earful. Oh, they don't care about us. They just want to fill the positions. I've been here 20 years and I didn't get a dime. That's going to be in the report. You don't want that to happen. RT department reputation is busyness. They can crank out treatments, but they can't measure anything and they don't know what their efficacy is, their efficiency, when they're using evidence-based medicine. Recruitment, true story. From this report, this goes back probably 10 years. They were advertising in the paper. I'm a seasoned respiratory therapist. I'm not looking for a position in the paper. They didn't advertise in their state society. They didn't advertise with the AERC. They didn't advertise for LinkedIn. Oh my goodness gracious, you're a dinosaur. That was in the report. Wage and benefits not consistent with area competitors, so we can't get them in the door again. Not for the RT director, that's an HR thing. Time to fill clinical positions over 9 months. That's a fact, and we need to know it before they come in the door. What we need to know is quantify the impact on staffing, impact on finance, impact on overtime, impact on use of agency staff. And the recruitment sign-on bonuses hadn't done anything. So again, some examples, final thoughts. Align RT operations with hospital mission, vision, values, and goals. Should have that today. If not, start working on that make that job one. RT must be accepted as an active participant in improvement efforts. Our name and if possible our credentials needs to be on everything that we collaborate with. RT leadership must add value through both expertise and leadership competencies. RT must be the driver of improvement efforts for safety, quality, and cost effectiveness. Got to be all three. RT leadership should provide consultant with pertinent articles, abstract, and information. And hardly anyone does this. You shake hands, you thank them after the final report, and immediately you get back to your desk and start cranking out information that you can send them to validate what you said during the engagement. This is our productivity system. And I promised I would send you our productivity for like the winter busy season and summer slow season, if that's used as example. Here it is. Here are 3 articles that support our current protocol. I'd really like to, if you have a couple of minutes, I'd really like to catch up with you and talk about the expertise that you have. And finally, offer to assist a consultant with future clients. I'd be happy to tell others how collaborative this was. Is there a way that I can do it? Can I communicate with your direct supervisor? And first base, second base, third base, home run. With that, I want to thank you for being an RT leader.